So what's new in mantle cell lymphoma? I guess the basic treatment hasn't changed very much. We understand frontline therapy, which in a younger patient is high-dose cytarabine-based treatment with a transplant, followed by rituximab maintenance. That's pretty much standard of care across the world. For older patients, those who aren't eligible for that more intensive style treatment, then it's going to be rituximab plus chemotherapy, and that's either CHOP-based or Bendamustine-based. And then we've got an old, frailer population where there isn't really a standard of care. The thing that's becoming clear is BTK inhibition. Those drugs, the earlier you use them, the better. So it's pretty much established now that you should be using these drugs early in the relapse setting. My personal practice is to use them at first relapse, where the evidence is that they are the most beneficial. What's coming is the trials using the drugs frontline. So there are a number of trials incorporating Ibrutinib in the frontline setting. The Janssen registration study, which was a frontline study for older patients, which was Bendamustine rituximab plus or minus Ibrutinib. We're still waiting to see the results of that. I've got a study running in the UK, which is also running in the Nordic group countries now, which is Ibrutinib rituximab frontline versus rituximab chemotherapy. Again, in the 60 plus transplant ineligible population. We've got almost 150 patients in that trial now, and that's very much going to challenge the paradigm. Do you actually need chemotherapy up front in that population? And then the young patient population, in the big European study looking at intensive treatment with or without Ibrutinib and asking whether you need to have the autologous stem cell transplant at all. So that's fairly established. I think what's new to me is that it's become clear that if you have a p53 mutation and you've got mantle cell lymphoma, you do spectacularly badly. So this is not CLL, where these new drugs overcome that bad prognostic feature. That doesn't seem to be the case with mantle. And the Nordic group have recently shown, particularly in their young patients in trials, that if you've got a p53 mutation and you use that high-dose cytarabine-based treatment, patients do badly. They relapse early, they progress early, using the new drugs doesn't work very well. So we need to do something slightly different. And my view is that we should be using allogenic stem cell transplant. And we are just about to publish, it's in press right now, a series of 25 patients in the UK who had upfront transplants, allogenic transplants. I don't advocate that for all patients, but I think for that group of patients who are p53 mutated, they do so badly, I think that's the right thing to do. So that's the first kind of risk-adapted approach to treatment there's been. We understand lots of prognostic factors in this disease, but they don't actually play out in how we treat people. We do these things, we recognize prognosis, but it doesn't influence our management. But that's one concrete incidence where it does influence management. It's only 10% of patients, but I think a slightly more aggressive approach up front is probably the way to go. I guess the question is, what do we do if we see those in older patients where we can't use those kind of treatments? And the answer is I don't know. But it may well be the combination of Ibrutinib plus venetoclax, which does seem to overcome that bad prognostic feature. That's based on a few patients treated in an Australian trial. But to me, that's a group of patients where you need to think slightly differently. Finally, I guess when we're talking about what's new is how do we treat people post-Ibrutinib? We don't cure anybody, they all relapse. And when they relapse, they're sometimes difficult to treat. I'm going to say a bit at this meeting, and we're going to present something at ASH about using a Bendamustine-based treatment in that group of patients, which works really, really well. So it's one of my ongoing themes, if you like, that in the world of very exciting drugs, don't forget chemotherapy, because chemotherapy works. So I think that's something that we need to bear in mind.